Hello, good morning, everyone. It is just my absolute true honor to welcome today's guest speaker, Dr. Kate Sullivan. She is truly a global leader in the field of clinical immunology, and she's one of the foremost experts on inborn errors of immunity. She received her MD, PhD from UCSF, and she is currently the chief of the Division of Allergy and Immunology, the original AI, at the Children's Hospital of Philadelphia, and a professor of pediatrics at the University of Pennsylvania. Dr. Sullivan shaped how we understand, diagnose, and manage inborn errors of immunity on an international scale. She served as president of the Clinical Immunology Society. She's led the USID National Registry, and she's chaired critical committees for the International Union of Immunological Societies, which really helps to codify the nomenclature and classification of these rare disorders, and all immunologists use those classifications today. So at CHOP, Dr. Sullivan has built groundbreaking clinical programs, including the Immune Dysregulation Program and the Joint Immunology Gastroenterology Program for very early onset IBD, which she'll be talking about today, both of which integrate genomics and precision medicine to tackle some of the most challenging patient cases. She also leads CHOP's participation in the Undiagnosed Diseases Network, where she oversees cutting-edge genetic diagnostics for children with elusive immune conditions. And with over 15,000 citations, an H-index of 59, and a career defined by collaborative innovation and impact, Dr. Sullivan brings unmatched expertise at the intersection of clinical care, genetic discovery, and translational science. So please join me in warmly welcoming Dr. Kate Sullivan as she talks to you today about very early onset IBD.
Thank you. That was overly generous. And I did hear that ChatGPT might have been involved. So there could be like a little hallucination in there, I think. I'm certainly not unmatched, goodness. I am super grateful to be here today. This is my first time in Pittsburgh, which I'm both excited about and embarrassed by. I should have been here before. I work in Philadelphia. It's not that far. So I'm really excited to be here. And I've been asked to talk about very early onset inflammatory bowel disease, which I'm thrilled to do. It's been an interesting evolution of my career to work in this, but I realize there's only going to be a small sector of the audience who's like super passionate about very early onset IBD. So I've tried to weave in some larger truths, and I hope you'll appreciate that. So this is what I'm going to cover. How do we think? I'm going to try and make the point that we're not great diagnosticians. We're very good diagnosticians, but we're not great. And it's just the reality of medicine. I'm going to talk a little bit about inborn errors of immunity because that's where I come from. I come from this as an immunologist, not as a gastroenterologist. But then I've been asked to talk about inflammatory bowel disease, and indeed I will. I'm going to spend quite a bit of time on genetics. And then I'm going to end with just a smidge of research on barrier function. And I think you'll appreciate why I think that's important in a minute. So if you are of my era, you know MC Escher. And this is just to make the point that our eyes can fool us. It is easy to go down the wrong path. And so I want to start with this idea of diagnosing patients. And I think this is informed by my work in the Undiagnosed Disease Program. Originally I had a couple of examples in here, but it was a detour from the message, so I took them out. But I think we can over-anchor on our initial thoughts about a patient and then forget the part where we come back and ask the broader questions. So pattern recognition is kind of the cornerstone of how we practice in terms of diagnosis, right? We see a 2-year-old who's febrile, has a high white count, and we worry about sepsis. And so we need those patterns because it helps us manage our patients, and we know it works. And we also know cognitively that it's flawed. It's not perfect. Not every 2-year-old with a high fever is going to have sepsis. We know that. But if we over-anchor, it can get us into serious trouble. And so that brings me to inflammatory bowel disease. And as I said, I'm not a gastroenterologist. And when I was first invited to join this group, I was like, no, not my thing. Sorry. And, you know, immunologists like colorful things. We like pretty things. We like tidy things, right? We do flow cytometry. We talk about things that are in little tubes, really not into poop and goop as a rule. And so I had to be quite convinced to join this group. And this is a woman I started following in the pandemic. She does immunofluorescence, and this happens to be a colon biopsy. And so I thought, well, there actually can be beauty in the GI tract. I just have to look for it. All right. Well, I'm going to start now talking about this idea that sometimes we have to broaden our perspective because if we narrow down too quickly, we'll miss something important. And that's really the thesis of the first half or 2/3 of my talk. And so this is, you don't really need any background in gastroenterology to recognize that there are ulcers here. If you looked at it under the microscope, there'd be white cells. And so the subtext is not all that is itis C is IBD. And that's because this is mycophenolate-induced colitis. So yeah, it's colitis, it's an itis, but it's not inflammatory bowel disease. So I'll give you the definition of inflammatory bowel disease down the road a bit. But again, you have to be really careful. We see not a case a year of mycophenolate-induced colitis, but we see about a case a year of drug-induced colitis. And we always have to make ourselves step back and go, oh yeah, that's how we got here. So there are some other clues. If you look at this particular case under the microscope carefully, it won't look like classic IBD, but you have to be aware that not everything that's inflammatory in the gut is IBD. So again, just to say that pattern recognition is important. I never want people to think I'm saying, oh, we should never use pattern recognition. We all use it every day and we have to. Just be careful about over-anchoring. So let me talk about the IBD landscape before I get into genetics, because our landscape is so different in the US than anywhere else in the world. It actually means we have a unique sort of genetic landscape, but to get to that, I need to explain the overall landscape. So if you haven't seen these papers, I would point you to them. There's a series of papers, the Global Burden of Disease set, and global burden of asthma, global burden of eczema, and here is global burden of inflammatory bowel disease. And they all have roughly the same figures in them. This is the age normalized prevalence of inflammatory bowel disease. And the giant red arrow at the top is the US. What's on the x-axis is what they call their sociodemographic index. It's roughly the gross domestic product for the country or the region. It's really a measure of their sort of financial wherewithal. Well, notice how high the US is compared to any other country or region. So the emerging economies down at the bottom, they have a very low rate of IBD compared to the emerging economies in the middle. And then the green triangles are the Northern Europe, which would be the closest to us in terms of sort of sociodemographic index. But our rate of IBD is much, much higher. And so that means the genetic contribution is going to be lower because we have such a strong environmental mechanism driving our epidemiology of IBD. Now, it is a general truth that in emerging economies, the rate of IBD goes up as the economy enters into its stronger phase. But at a certain point for IBD, that plateaus. And at that point, the age of onset gets younger and younger and younger. So this was first described in this paper from Canada, but it's been repeated in the US and in Northern Europe. So as the economy gets stronger, as people are industrialized, the rate of IBD goes up. For that country or region, there will be a ceiling effect. And at that point, the age of onset gets younger and younger. That means there's more and more very early onset IBD in the US. And I've seen that even in the 15 years that I've worked with the VEO IBD group. So just in that short time frame, we have seen the epidemiology change. Now, I'm always asked, what are the reasons? And no one really knows. These are the reasons that are commonly cited. So change in microbiome, which is related to the increasing use of antibiotics. But I would like to point out there are countries in Asia, for example, where antibiotics are quite freely distributed and they do not have a high rate of IBD. So I'm not doubting that there is a contribution. There have been multiple studies showing that early use of antibiotics raises the risk of IBD. I think that increased intestinal permeability is probably a bigger driver. So these foods that are highly processed, and in particular foods that have surfactants and emulsifiers. And if you consider yourself a very clean eater, if you have anything in your fridge or your freezer that is semi-solid or liquid, almost surely it will have a surfactant or emulsifier in it. So salad dressings, ketchup, believe it or not, ice cream, anything like that in your fridge or your freezer is going to have an emulsifier and or surfactant in it. And that's what keeps things in emulsions, and it keeps them from separating, and it keeps them smooth if they're in the freezer. So at the very end, I'm going to come back to this idea of altered barrier function, but we do know that it's quite problematic, and you'll see that reflected in the genetics when I start talking about that. And then the Western diet's just bad for us. We all know that. So IBD is occurring younger and younger in industrialized countries. If you haven't seen very early onset IBD yet, you absolutely will. So it's defined as onset less than 6. Because there's so much of it in the US, there's actually a move to redefine it as onset less than 5 years of age, but that hasn't caught hold yet. So right now it's defined as onset less than 6 years of age. So why is an immunologist important for VEO-IBD? I wasn't really sure when I was asked to join this group, but since it's been, I guess, a little bit clearer for me. And Hay talked about this inborn errors of immunity sort of tabulation committee that I'm on, which sounds incredibly boring, but people get really feisty when it comes to their favorite gene. So what it is, it's a compendium of the 550 genes that cause inborn errors of immunity. But because 550 is a lot and no one can remember them, we sort of divide them into different categories. And I'm telling you this just to make the point that inflammatory bowel disease crosses all of these categories except complement deficiency, which means you can't really say, well, you need to think about IBD for the T cell deficient people. You need to think about IBD for the neutrophil deficient people, because IBD is happening in all of these inborn errors of immunity. And in fact, autoimmune disease in general is increased in inborn errors of immunity, and inflammatory bowel disease is just one component of it. And I think that sometimes surprises people because you think of primary immune deficiencies as too little immunity and autoimmunity is too much, but it's not really so much about quantity as it is kind of making a wrong turn. So often you can be quite T cell deficient, but if your T cells don't recognize what they're supposed to attack, they're also not very good at recognizing what they're supposed to protect, our own bodies. So in general, autoimmune disease is increased and IBD is one of those. Now I'm going to start with a few examples from my world, the world of inborn errors of immunity. And I have a particular agenda here, but I'm not going to share it till I'm completely done. So this is the most common inborn error of immunity that we see in our immunology clinic and most immunology clinics around the world. And that's common variable immune deficiency. It's an antibody deficiency. It can occur at any age, but it has a particularly high rate of gastrointestinal disease. Not all of it is IBD. They get other types of intestinal woes. And it's been shown that once a patient with common variable develops inflammation of their GI tract, their life expectancy is about 8 years. So not only is a horrible impact on their quality of life, but it also markedly affects their survival rate. And so as you can see, there's a range of different types of gastrointestinal issues, including this enteropathy, which looks like celiac disease, but is not gluten responsive. But I'm going to talk about the IBD and common variable. And so, as I've mentioned, it confers quite a poor prognosis. And definitely, I remember so clearly the first patient I met with this, he could not work because he couldn't get in his car and drive for an hour without being sure he could get to his destination. He was having 10 to 12 stools a day. And so getting in a car for an hour was an impossibility for him. Really impacted his quality of life. So as an immunologist, there are some basics. Of course, we want to rule out infections, but here specifically for common variable, the treatment we use is a drug called abatacept. You might know it as Orencia. It's a drug that was developed to treat arthritis, but has since been co-opted by immunologists to treat T-cell mediated disorders, and it works very well in common variable. If there is a genetic etiology to common variable, then you would want to target your therapy to that gene, and I'll get to that in a minute. What about X-linked A-gamma globulinemia? This is another antibody disorder, but this is an antibody disorder where kids are born without B cells, the cells that are critical for making antibody. And the inflammatory bowel disease occurs in about 5 to 10%, and it's quite age dependent. So the adults have a much higher rate than the kids. I've had folks respond to antibiotics, even though they didn't really have a clear infection, but I've had some kids respond to antibiotics, and actually antibiotics is a recognized treatment for inflammatory bowel disease. And some respond to TNF inhibitors, so that's my first choice. I always confess that although I have not had a TNF resistant case, I've heard from other people, so I know there are some cases that do not respond. And here again, you would want to rule out infection. You know, if they're immune deficient, you want to think about that. And here's my last of the troika of examples here. This is chronic granulomatous disease. This is a neutrophil disorder. So 50% of the adults with the X-linked form of chronic granulomatous disease have IBD, and transplant works beautifully. But we have to get them to transplant. And so we mostly use an IL-1 inhibitor. NIH prefers ustekinumab, but you do not use TNF inhibitors in chronic granulomatous disease. So what's my point here? In all of these examples, the IBD looked the same, right? Looked the same under the microscope. Everyone was having diarrhea, but the treatments were based on the underlying disease. So I talked about abatacept, TNF inhibitors, and I talked about IL-1 inhibition. So very different treatments that were specific for their gene or disease. And that's a point I will make several times more. So I've been talking about IBD, and I think it's time to talk about what it is and what it isn't. So before you get to pathology, the definition of IBD requires you to rule out medication-induced inflammation or infection-induced inflammation. So most gastroenterologists right away will send a culture and an ova and parasites. But presuming you've gotten past that point, then it's all based on pathology. And so I'm just going to spend a minute here. And so on the left, you'll see a normal colon. So notice the crypts are narrow and tall, and they're smooshed together, right? It's like a bunch of pencils all together, all straight and true. So those are the crypts, and they're lined with clear cells. So they look like cells that you can see through, and those are the mucus-producing cells. So this is a very normal colon. On the middle and in the right, these are two from patients with IBD. So notice these look nothing like the panel on the left, right? So in the middle, we've got branching crypts, and the crypt in the middle has a crypt abscess. So this is really common in IBD. It's just a bunch of neutrophils sitting in the bottom of the crypt. But notice how sparse the crypts are. There's only two and a half. I guess there's another one. And so everything in between the crypts, it's all inflammation. And if you looked at it, it would be a combination of neutrophils and lymphocytes, usually some plasma cells as well. On the right, it's a little bit torn up, but you can see, again, a lot of inflammation. And so just under the microscope, it looks very different. You can't just have inflammation, though. You need evidence of chronicity to call this IBD. The easiest way is to look for crypt distortion, which is what I'm showing you here. Now, in the small bowel, it's a little bit different. So the small bowel has villi instead of crypts. Well, they do have crypts, but they have villi that are more prominent. So, but same idea, right? They're taller than they are wide. They do have some cells in the middle, unlike the crypts, but you also see mucus-producing cells. On the right, I'm showing you a slide from a patient. If I didn't tell you the lumen was on the left, you'd probably be hard-pressed to identify any villi at all. There actually are 3 very stumpy villi on the left of this. So this is villus blunting, very typical for T-cell driven inflammation in the small bowel. Okay, so the pathology is required for diagnosis, and it generally drives the diagnostic category, meaning Crohn's or ulcerative colitis. Now, you haven't heard me talk about Crohn's and ulcerative colitis, and it's in every textbook, right? The reason is for VEO-IBD, it can be really hard, right? These are 1-year-olds, and it's hard to partition them into UC or Crohn's that early in life. So you'll see in a minute, we have a big clump of kids that we call undifferentiated because we just can't tell. We're not willing to put them in a bucket until we're for sure. But the point I really want to make is that there are endophenotypes that are not captured at all by Crohn's and UC. So for example, there's heterogeneity in location. Even in ulcerative colitis, which in theory should be restricted to the colon, there can be heterogeneity in location, and there are actually outcomes that are driven by that phenotype. There's heterogeneity in drug response, there's heterogeneity in extraintestinal complications. So we know already that it's more than just Crohn's and UC. And so it's a little bit disingenuous to say, oh, I've made the diagnosis, when we know that there are lots of differences that really impact outcomes and also treatment responsiveness. So now, if there are gastroenterologists in the audience and I say something right, you can thank Judith Kelson, because I did not come by this knowledge naturally. I was painfully, from her perspective, taught all that I know about gastroenterology. She's really quite amazing. And here is the team that she's assembled. And it's a group of people that provide wraparound services. So psychology, social work, as well as research and clinical care. So it's really meant to be a complete wraparound set of services, but also a research-based program. All credit to Judith. And here's what I've learned about gastroenterologists. They love to party. So in allergy, we can't party because someone's got a walnut allergy. Oh, we can't go to that restaurant. But the gastroenterologists are like, let's party. We'll figure the rest out later. So I love hanging out with them. It's been great. All right, well, let me come back to a little bit of data here since that's really what I'm here for. So I want to give you a sense of what the landscape of VEO IBD is compared to older onset IBD. So this is a study we put out some years ago looking at kids. The data that I'm going to show you are actually kids with onset over 10, but just to show you, there's not really any difference in the distribution of Crohn's you see in undifferentiated between the two groups. So the point I want to make is that the VEO IBD kids, they have a very high treatment failure rate compared to the older onset. So TNF inhibitors are the mainstay of treatment. They're the first biologic most people reach for. So you can see that among the VEO IBD group in blue, what I'm scoring here is treatment failure. Over half of the kids are going to have primary failure of TNF inhibitors. Other immune modulators, it's even higher. So they have a very high treatment failure rate. We do a lot of empiric management. We do combinatorial management. These, not all the kids, there are some kids that turn around like that, and we're so happy, but many of the kids sort of miserably cycle through biologic after biologic looking for an answer. Well, related to that is their very high rate of surgical intervention. We do everything we can to avoid colectomy. I mean, honestly, we do everything we can. But because of the severity of disease, the kids with early onset have a higher rate of diversion and colectomy. Now, there's also a little bit about the pathology that I didn't tell you that differs in VEO IBD, and I want to share that with you now. So I shared with you the classic features of IBD. But VEO IBD has a couple of differences I want to share with you because they can really be foolers. And so one is crypt apoptosis. So this is a crypt now cut in cross section. And so you're sort of staring down into the middle of the crypt, and the cells that line the crypt, there are some that have sort of a white halo around them. Those are cells undergoing apoptosis. That's actually a huge amount of apoptosis, even by our standards. So it's not that crypt cell apoptosis isn't seen in older onset IBD, but usually it's seen in kids that are super, super sick, having a major, major flare. In VEO IBD, it's like run of the mill. So half of our kids will have crypt apoptosis at the time of their initial biopsy. The other time that you see it, and believe it or not, I've taken several calls from pathologists, is graft versus host disease. So if you knew nothing about this particular slide and you handed it to a pathologist, likely they would say this looks like GVHD, because it really does. The other thing to note is that in VEO IBD, we see a lot of eosinophils. So if you look quite carefully, you'll see some fuchsia sprinkles in the lamina propria as well as in the crypt. Eosinophils are a cell that love to show up to a party. And so before I worked in VEO IBD, I did some rheumatology. Eosinophils love to show up there too. So especially early in an inflammatory process, all the cells come to play, including eosinophils. So this isn't FPIES, it's not food protein-induced enterocolitis, it's not EGID. This is just some eosinophils showing up to be part of whatever inflammatory response is going on. So we again see it in about half of the kids with VEO IBD. But where I have really sort of maybe brought the greatest value to the VEO IBD group is through genetics. So I'm going to spend a little bit of time talking about that. And I know you all know this. I like to just start with this slide to make sure I'm not saying it in a different way than what you're used to. So when I worked in lupus, I had a slide that looked just like this. So this is generally a model for most autoimmune diseases. So we think there's something from the microbiome, there's something from the environment that maybe is infection, and there's something from the gene. But the point I want to make is sort of the 5 beakers that I've drawn at the bottom. So the idea is the red line is the threshold past which you will develop disease. So hopefully most of us in the room are on the left. We maybe don't have a perfect diet. Maybe we took an antibiotic. And we probably inherited a couple of variants that place us at risk for IBD. But it's not enough to push us into having disease. Next to that is the monogenic VEO IBD, which I'll be talking about more. Here, one gene is the big kahuna. It's what's pushing the patient past into developing disease. We have one case that is proven digenic. We imagine in our head that there's trigenic. But typically when we think of adult onset or teenage onset IBD, it's the kind of gamish on the right. So it's a lot of environment, a lot of microbiome, and then maybe 10 individual genes that individually don't contribute much, but collectively sort of push past that threshold. So that's sort of the landscape that I'm talking about here. And these are genes taken from the United Kingdom IBD Consortium. And so they sort of monitor all of the GWAS studies. So what I've done is I've taken the GWAS hits from their website and I've just partitioned them into these 3 different compartments. So the innate immune system, the adaptive immune system, and barrier function. I've already mentioned I'm going to come back to barrier function at the very end. It is clearly very important. The genes that are sort of shaded a little bit, those are genes that are common between UC and Crohn's. So they even have a very common genetic underpinning. We would say their genetic landscape is very similar. And weirdly, the genetic landscape is similar for all autoimmune diseases. So if you do sort of a heat map of correlation, almost all autoimmune diseases coalesce very, very similarly. So there are commonalities between Crohn's disease and UC. There are also some differences, but they all 3 boil down to these 3 categories. These are the genes as of 2 weeks ago from our VEO-IBD cohort. Our rate of monogenic etiology is 10% overall, 20% among the infantile onset. Notice it's quite far away from 100%, which might surprise you. In other countries, the rate is higher. So in the Middle East, the rate is typically in the range of 30%. In China, it's about 20%. Because there's so much IBD in the US that's driven by environmental things we can't name, it means the percentage of kids with monogenic VEO-IBD is lower. So you probably can't read all these genes, but I wanted to list them here for a reason. And notice there are some chromosomal defects as well. So there's Turner syndrome, trisomy 21 and 22q deletion. We've helped to identify 2 new genes, but I like to show this list, even though it's not probably readable, to make the point that it's super hard to develop a panel. So I'm often asked, can I send a panel somewhere? I can't get exome sequencing. Can I just send a panel? And the answer is yes, you can send a panel. There are some that have a reasonably good hit rate, but none of the panels have all of those. Now, similarly, I'm often asked, can I screen for the monogenic etiology by doing standard tests of immunology? And the answer is, again, yes, you can, of course, but the likelihood of finding folks is actually pretty low. So I've boxed the genes in which a standard immune evaluation might be expected to yield an answer. You can see it's actually quite a small minority of the genetic etiologies. And so the top genetic etiology, CYBB, you might not know the gene, but that's chronic granulomatous disease. And so these are typically babies. They don't have a history of infection. They just show up in our VEO-IBD clinic. So we always test for chronic granulomatous disease because that test comes back within a day. But otherwise, we do not do a lot of immunologic evaluations because they tend not to yield very much. And we go right to genetics. And so if we take our genes and map them out like I did the GWAS hits, you can see it's exactly the same. There are folks that got there largely because their barrier was dysfunctional. There are kids that got there because their innate immune system was dysfunctional. Kids that got there because their adaptive immune system was dysfunctional. So it looks exactly the same as the polygenic kids. So the mechanisms of disease are the same. It's just the magnitude of the genetic contribution is different, and it's always immune and barrier. So I'm often asked, what about the secretory diarrheas, right? That's not really barrier function, kind of is, but we actually never see those kids. They do not show up in our clinic. And I think it's because we are, shall we say, very aggressive in doing endoscopy. So I think they get diagnosed before they ever make it to our clinic. So how do we find the monogenic cases? If you can't screen with standard laboratory studies, how are we finding them? Are there any screening tests to stratify the patients? And the short answer is not really. So I've already said that the standard immunology tests are not very useful in terms of stratification for monogenic etiology. This was actually a study we did for another reason, but I'll just show it to prove my point. So the monogenic cases are on the left and the polygenic cases are on the right. And I'm just looking at 3 T-cell markers here. You'll notice that there are 2 kids that are fairly low compared to the polygenic cases. And those were kids that had a known form of SCID. They had multiple intestinal atresia. So they were picked up on day of life 1. And so it wasn't really mysterious. So there are kids who have low T-cells. And we've had a couple of RAG1 SCIDs come to our clinic as well. But again, they were known before they made it to our clinic. So what about family histories? Pediatricians were always taught to take a family history. And here's the sad truth. There is so much IBD. The family history isn't that useful. 1% of the population in the US has IBD. So it's not often helpful unless there's a really clear inheritance pattern. It's like grandma, mom, child. If it's something like that, we absolutely pay attention. But otherwise, the family history, if it's, Aunt Mary has IBD, that doesn't help very much just because there's so much IBD in the US. So we were very disappointed by all of that, as you can imagine. When I joined the clinic, I thought, I'm going to do the labs that I know and love. I'm going to find these kids, I'm going to take them back to my clinic and take care of them. And A, that was wrong because I can't manage them. I have to work with a gastroenterologist. And B, my labs aren't very useful. Doing lymphocyte subsets, not very useful. So we said, okay, our hypothesis was wrong. So we did a machine learning model where we took all the variables in our database and we said, all right, computer, you tell us what segregates with monogenic etiology. And the only two that were statistically significant were panenteric disease and short stature. But statistical significance doesn't always play out as clinically useful, right? So we have a lot of monogenic cases where they have neither panenteric disease or short stature. So it's a nice statistical association, and we had a lovely paper out of it, but not useful on a clinical basis. So here's my personal take. So I often hear from people, I can't get genetics on everyone. What can I do? So if I see small bowel enteropathy with a lymphocytic infiltrate, I will go to the mat with that insurance company to try and get genetic testing. And why? It's because the gene will tell you the drug that's going to work in that circumstance. If it's infantile onset, again, I will do whatever I can. I'll do peer-to-peers till I turn blue. Panenteric disease and severe growth failure, those are the scenarios where I will really do everything in my power to try and get genetic testing. And I'll explain more about the small bowel enteropathy in a minute. Now, we are big believers in genetics, and we have a research program where we can sequence everyone. So I realize we're in a somewhat unusual circumstance, but it has allowed us to make these following, I don't know if they're truths. These are associations and beliefs that we hold. So knowing the gene defect can help target therapy. So there are some that we take to transplant. So if we see chronic granulomatous disease, if we see XIAP and it's a youngster, we try and take them right to transplant. Not every family wants to, but we certainly make a strong case that they'll be better off with transplant. For dyskeratosis congenita, we use danazol. We actually don't think it works, but it's in the literature. And you can see for the others, for CTLA4, LRBA, PIK3CD, these are the primary immune dysregulatory conditions, and they tend to respond well to T-cell therapy like sirolimus and abatacept. CARD8 and ELF4 are two genes that we know respond to IL-1 inhibition, and NLRC4 and XIAP respond to IL-18 inhibition. So knowing the gene is the ticket to optimizing therapy. It can also determine what not to use. So there are some settings where there are treatments that have been proven to not work. Now, this is not unique to us. So there's a study of autoimmune cytopenias showing that the people with known monogenic etiology and autoimmune cytopenias had a better outcome than the non-monogenic cases. And why is that? It's because you can land on the right treatment sooner than just fishing around and guessing, which is what we often find ourselves doing. So it's not unique to IBD, but the gene is really the way to get to optimized therapy. Well, how's it all going? Well, great if you have a monogenic etiology. So all of our cases that have had bone marrow transplant have had excellent outcomes. We're really thankful for that because that's not a given by any means. And all of the ones on medical therapy directed according to their gene have done very well. We haven't had any primary treatment failures. But let me tell you a little bit about bone marrow transplant because that might surprise you. Why would you do a bone marrow transplant for IBD? So Alyssa Baccarella just collected our recent data on 25 patients. And we did have one patient that had an older onset, but this is largely a VEO IBD cohort. And the answer is 1 and 2 years out from transplant, they're doing great. They're in remission. If you look at their catch-up growth, they've had a lot of catch-up growth. So remember, short stature is one of those phenotypic anchors for monogenic etiology. But after transplant, they catch up. They're not basketball players, but they do catch up. So it's clear that it has a very salutary effect on their outcomes, and we're very pleased by how well these folks have done. We have not done a non-monogenic case yet, although we have one that we have proposed that we're moving towards transplant. So my take-home message is, this is just sort of an interim summary. There's no substitute for genetics. It's super hard to stratify for genetic testing based on labs, family history, or clinical history. So this pattern matching just isn't effective. There's nothing really to hold on to. You have to just sort of dive in. But I did give you some times where I feel really strongly genetics is important. But what if there is no gene? So it's monogenic in 10%. What do we do with the other 90%? Seems cruel to just ignore them. So here we do use pattern matching. So here we have some folks who look like they have familial Mediterranean fever. They don't, but they look like they have familial Mediterranean fever. They have a lot of fevers and they have high inflammatory cytokines, and they were put on the treatment we would normally use for IBD with FMF. They were put on IL-1 inhibition, and they did great. So 18 kids who had a super inflammatory phenotype, they got put on canakinumab, which is a longer-term IL-1 inhibitor, and they all entered remission for the first time. So here we used clinical pattern recognition. We said, well, if it looks like familial Mediterranean fever, maybe we should treat it like familial Mediterranean fever. Doesn't always work, but it did work there. And then our second case was ruxolitinib. So here it was lab-based pattern recognition. We usually run a cytokine panel on our sickest patients. It just shows sort of the flavor of inflammation that you're dealing with, and sometimes we use it to help target therapy. So these were kids who had all of their inflammatory cytokines elevated. So we used ruxolitinib, which would sort of suppress multiple cytokines, and these kids did great. So they normalized their SED rate. Ruxolitinib is now approved for IBD, but at the time we did it, it was not. So we're really pleased to see how in this setting pattern recognition was successful. We also use pathology pattern recognition to guide therapy. So under the microscope, if it looks like classic neutrophilic abscesses in the colon, we treat them like classic IBD. If it looks like small bowel enteropathy, we target T cells. T cells are the cells that are largely driving the villus atrophy. So we use sirolimus, abatacept. Here we also like JAK inhibitors and tacrolimus. We don't use much in the way of steroids. So we'll use it in some settings, but not very much. And then I put in the blue box to remind me to say that we use a lot of nutritional therapy. So strangely, if you give kids formula, instead of letting them eat whatever they want, the success rate of that treatment is roughly on par with steroids. Same thing is true for triple antibiotics. So it means that you can change the microbiome in a way that really decreases inflammation, and that can be your primary therapy. Neither of those treatments tend to be very durable, but we really love them as bridging therapy to help get kids if they're waiting for some other drug. So they can be really surprisingly effective, and we do like using them. Well, it's been a puzzle to me that if we can cure IBD with bone marrow transplant, why don't our drugs cure it? If you can put someone in remission with treatment, why is it they can never come on? Why is it if you've interrupted that cycle of inflammation, they can't reset their homeostasis and get back to a non-inflammatory state? Why isn't immune modulation enough? So I'm just going to end with a teeny tiny bit of science here. And there are some studies showing this barrier function that I've spoken about is really kind of a big deal. And so in asymptomatic family members of folks with Crohn's disease, there's a pretty high rate of increased gut permeability, suggesting that there's maybe a polygenic basis for impaired barrier function. It's also the case that patients with Crohn's disease, the higher their gut permeability in remission, the more likely they are to have a flare. And so this says that while we maybe have fixed the immune system, we haven't really fixed the gut. And there are two people that have been doing in vivo evaluations of barrier function in real life people using endoscopy. So they inject acridine orange, and you can actually see holes in the gut when you do that. So that made us interested in what could be going on. And I'll just show you a teeny bit here. So what holds us together in general, not a subject I spend a lot of time talking about, but these tight junctions are the things that glue all of our cells together, essentially. But there are different proteins in our skin than in our gut than in our lung, but it's always a tight junction structure that is responsible for holding us together. The adherens junctions as well, and the desmosome, which if you haven't seen one, desmosomes are quite attractive. And so let me show you what we have been doing. So we designed sort of a monolayer approach to looking at cell adhesion. And for this, we use CACO2 cells, which are intestinal epithelial cells. And then we kind of opened our freezer and said, let's throw every inflammatory stimulus we can think of at these poor cells sitting in this tissue culture flask. And then we did microscopy. So I'm just going to show you one example of this, because I actually think they're quite attractive. So hopefully on the left, you can see that while the cells come together at the vertices, there are clumps of Zo3. So this is zonial occludens 3. It just happens to be one of the intestinal tight junction proteins. The cells are outlined by it, but there's a particularly high amount at these junctions between multiple cells. When we treat with TNF, that sort of goes away. You end up with beads on a string, so it looks quite different. The protein is actually rearranged on the cell surface. It's not so much that the amount of the protein has changed, but its distribution has been altered. Now, we have now shown this for all of the tight junction proteins and with many of the inflammatory stimuli. We're not the only people to show this. So this is a study that uses a completely different technology called cryo-EM, where they basically flash freeze a biopsy from a patient, and then they crack it open. And so it cracks in a way that the cells split between them. So now you're looking on the face of the cell here. And if you look in the upper left, it sort of looks like a chain link fence. Those are lines of tight junction proteins. And that's what's holding the cells together. But now you're looking at the face of the cell. The two on the right are from patients with Crohn's disease. So these are real live biopsies from people. And you can see that the tight junction proteins now have rearranged to look at this like pearls on a string idea. So we think this is a global phenomenon as a response to inflammation. And so we asked the question, is the barrier defect durable? My lab is an epigenetics lab, so you can probably tell where this is going. So we first collaborated with Kate Hamilton, and Kate grows little miniature intestines in a petri dish. Isn't that cool? So these are called collonoids, and these are taken from people and then minced up in a petri dish. And the stem cells populate a brand new miniature intestine. And so the outline that's in pink is the intestinal wall, and the interior that's blue is mucus. And so these grow quite happily, and you can split them up and do it all over again. The stem cells will repopulate and regrow more and more collonoids over time. So do those collonoids reflect where they've come from? So remember, they've undergone multiple rounds of division now. They're very far removed. They're months removed from the person that they came from, but they carry a memory of where they've come from. So in the top graph, what I'm showing you is the crypt conversion ratio. And so this is the fitness of the stem cells. So the stem cells are just not as fit from VEO-IBD. Even though they've been out of the body for a couple of months, they still remember where they came from. And the same is true for gene expression. I happen to pick DR here, but the same is true for gene expression. If you just grind them up and do RNA-seq, they look very different, even though they haven't seen an inflammatory stimulus for months and months. So the changes to the epithelium are quite durable. And because our expertise is epigenetics, we said, this is something we can work on. And so we took the same stimuli that I showed you from the immunofluorescence, and we said, what's it doing at the level of epigenetics? And so H3K27AC is a mark of transcriptional competence. So you can see for all of the inflammatory stimuli, it goes down, suggesting, this happens to be occludin, but it's true for most of them. It shows that occludin is less able to be expressed after exposure to these inflammatory stimuli. So I do think there's a reason that the epithelial defects aren't reversible. I think they remember that they've been hit by something. All right, so here are my big messages just to end up here. VEO-IBD can be a severe disease with significant burden. I hope you took that away from the studies that I showed with the outcomes. And they have more years of disease, right? If you start as a 2-year-old, you could potentially have 80 years of disease. So I think we do need to do better. I think genetic testing is critical, and I would urge you to get it specifically in the scenarios I mentioned, but as much and as often as you can. And it sounds like Hay is able to get genetic testing easily. We're poised to exploit phenotype and omic strategy to stratify for treatment. I do think we're getting there. I think we've taken a few baby steps. I don't think we're there yet, but I think we will get there. So I also took some life lessons away from this. So gastroenterologists are a lot of fun. They eat very well. It's not all goop and poop, but the goop and poop story is kind of interesting. And you don't know how old I am, but I started this in my 50s. It was like a lovely kind of thing to be engaged by late in my career. And I think it's actually been a wonderful, rejuvenating experience. And then I'll just end where I started. Patterns are a good start. We cannot avoid pattern recognition, but sometimes you have to go a little bit farther. And I do think genetics is one example where that's true. We can't always guess what the etiology is. I think we just need to sequence in most cases. So I'll just end by thanking my lab. Lee Song, Kelly Maurer, and Chris Breen did all of the lab studies that I shared with you. The VEO-IBD group, I've already credited Judith Kelson and Alyssa Baccarella. Kate Hamilton did the collonoids. And this is my lab looking for the eclipse. Does everyone remember the eclipse from a year ago. We had a cloudy day. I'm not sure what your weather was like, but we were excited nonetheless. So thanks to my lab for always bringing enthusiasm. And I will end there.